Assalamu alaikum. Good evening, everybody. Tonight, inshallah, we have two cases will be presented by Dr. Majid Al-Mutairi, who is fellow in gastroenterology first year in his fellowship. First case will discuss unusual presentation of a common scenario. Then we have a discussion after that and topic review. I am Dr. Muhammad Al-Khatami, consultant gastroenterology from Security Forces Hospital.
Start?
Yeah.
Bismillah, assalamu alaikum. Good evening. Today we will present a case about a young lady, which is start now. 21 years old, Saudi female, not known to have any medical illness. Present status post spontaneous vaginal delivery around for her first baby around 7 days back. Present today are with history of abdominal pain, which is diffused, progressive abdominal distension, and fever for 5 days. Patient was in her usual state of health 14 days prior to her delivery, 7 days prior to her delivery, when she started to have watery diarrhea 10 to 15 times per day, vomiting 3 to 4 times per day, and undocumented fever on and off. She sought medical advice as private clinic, received intravenous hydration only, and went home. No medication given because of her pregnancy, as she claims. Patient was in her usual, next one. Yeah. 7 days later, she had spontaneous vaginal delivery at private hospital with no complication, which she went home the second day and from the private hospital. Third day of the delivery, she started to have this progressive and diffuse abdominal pain. Distension and fever were associated with shortness of breath. She tried to manage at home some herbal herb, which is Helban Girfa. You know what's the meaning of Helban Girfa, by the way? What's Helban Girfa?
Cinnamon and fenugreek.
In English.
Cinnamon and fenugreek, okay.
Fenugreek. And fluid diet, but didn't work. During this period, her diarrhea was persistent, became worse, and recently as well. So she, on day 6 of the delivery, she went to private hospital, which she did the ultrasound abdomen, found to have liver mass and ascites. After that, she signed DAMA from this private hospital and gone to Security Forces Hospital, Bagram, in the ER. So, apart from her current complaint, pregnancy was uneventful. She didn't take any supplement during her pregnancy or any medication. Other symptoms like BR bleeding, hematemesis, jaundice, or change of consciousness was negative. Also, there is no itchiness or history of liver disease, no history of contact of sick patient or TB patient, no family history, and no association with skin rash or joint pain. Lastly, she has no history of DVT. In social history, she's happily married. Her and her husband live in Riyadh, good socioeconomic status, and studying in a college. Past medical family history also unremarkable, not known to have any allergy to any medication. Next, please. Examination. Patient was conscious, oriented, time-blessed person. She was unwell, sick, lethargic, not jaundiced or cyanosed. She was tachypneic, tachycardic. Her temperature dehydrated with this one. With dry mucosal membrane and decreased skin tiger. Vital signs, like you see, his pulse was normal, 120/70. Blood pressure was normal, 120/70. Pulse was, she is tachycardic, which is regular, and temperature, she was febrile 39.5. Oxygen saturation was 100% in room air. Respiratory rate was she was tachypneic a little, 16 to 20. Head, ear, nose, and throat examination, including the thyroid, was normal. no lymphadenopathy, no stigmata of liver disease. GVB was normal. Mild bilateral lower lymphedema and intact peripheral pulses. An abdominal examination, the flank was distended with full flanks, no scar, no deformity. She had diffuse tenderness, positive rebound tenderness, but soft, no palpable masses. She had positive shift tone dullness, which is the most significant one, an audible bowel sound. No browier venous hump. She refused PR and genitalia examination. CVS was unremarkable other than tachycardia, central nervous system, and chest examination also the same, and musculoskeletal also unremarkable.
So here we have, in a summary, 21-year-old female. She just delivered 7 days ago. She had history of diarrhea 7 days prior to delivery, which continue for another 7 days prior post-delivery till she came to our hospital. 3 days post-delivery, she had abdominal distension, fever, and continuation of her diarrhea and vomiting. Physical examination showed evidence of ascites and lower limb edema with tachycardia, significant tachycardia. Heart rate was 160 and temperature was 39.3. So any thought or impression at this level?
I think in first differential diagnosis, this scenario is infectious disease. She had the colitis-like syndrome and fever, chills, etc., and liver mass. Apparently, it's coped with, like I think, amoebic dysentery, amoebic ascites, abscess in the liver, and amoebic colitis. This is my first thing.
Okay. So, any other thought other than amoebic colitis and amoebic liver abscess?
Acute colitis and dysentery can be associated with liver abscess, but the ascites we cannot explain. The ascites, yeah. Actually, but if it's acute enterocolitis, fever, chills, and the liver mass, maybe it's dysenteric abscess, amoebic abscess.
Okay. So we have acute diarrhea, liver mass, and ascites.
Yeah, ascites is
Plus, patient has tachycardia and fever.
Not fit ascites.
Any other thought?
I'm sorry, I came late. She has a liver mass as well?
Yes, this done ultrasound outside in private hospital. They told her she has liver mass with ascites. Okay, valid differential diagnosis, but Chiari. But how to explain diarrhea, fever, tachycardia, leukocytosis of 39? Okay. Again, how to explain ascites with Shigella and Campylobacter? So, any other thought or differential diagnosis that can collaborate all symptom signs together, or could be two different entities came at same presentation? So we, from our side, we have the same, what? Phlebitis? Phlebitis, at which level? You mean vasculitis?
Vasculitis or phlebitis.
Okay. So we have almost the same differential diagnosis as you mentioned, colleagues. Infectious colitis, although the explanation of ascites and lower lymphedema is still not clear. We have how it come.
Cases of fulminant amoebic dysentery, and sometimes we have ascites also, but it's not very frequent. But you can have ascites.
Okay.
It can be seen in cases of postpartum cardiomyopathy. Can present
present postpartum cardiomyopathy can present with ascites, lower leg edema,
But-
and superimposed with infection probably.
Okay, so you mean infection, precipitate, decompensated cardiomyopathy. Okay. So
Next.
we'll proceed to our lab investigation, then we will see.
In investigation, we see WBC, she has leukocytosis, male neutrophils, and 39,000.5. Hemoglobin and platelet were normal. Liver panel were normal, other than significant hypovolemia in 17. Renal function was she has hyponatremia and chloride decreased little also. Urinalysis was normal, coagulation profile were normal. Amylase normal, glucose and corrected sodium also was normal. ESR was normal 12, C-reactive protein was high 378, and LDH was also around 1.5 double normal, which is 325. Lactate was normal, cardiac enzymes were normal, and ECG showed sinus tachycardia. This is just X-ray of the patient. Looks normal. Here we can see lateral view, which is seeing a little alteration of the costophrenic angle. This is abdominal X-ray, which shows dilated large bowel lobes. This is the X-ray also of the abdomen. See significant dilation of the bowel lobe without significant fluid level. CT, she did, when she came to the ER, yeah.
How many centimeter diameter of transverse colon?
For her, it was when we discussed with the radiology, he told it's not that significant. It's around 4 to 5 centimeter, and you have to measure it on the screen itself. So it was
Less than 6 centimeter.
CT, spiral CT done for her in the ER as part of differential diagnosis. They put the PE as part differential because of the tachycardia and her
Shortness of breath.
breath. So they did a spiral CT, which shows negative for PE, bilateral pleural effusion, more on the right side, lung parenchyma, grossly unremarkable. She did also echo, which showed tachycardia, normal cardiac chamber, ejection fraction above 70 with no valvular abnormality. Ultrasound Doppler throughout DVT was negative for DVT. And this is CT abdomen done for her. You've seen sites here. Can you go to the next one? There is hypodense lesion in the liver, you can see.
So we have slight peripheral enhancement
Yeah.
with central hypodensity, so suggestive of focal nodular hyperplasia. And we can see here as well ascites.
And
As well, we can see diffuse large bowel wall thickening with few mesenteric lymphadenopathy. As well, we can see involvement of the terminal ileum and significant ascites. So this is the final report from the radiologist after we discussed with him.
which is he showed distended large bowel lobe, distant and distant part of terminal ileum. Can you go next slide, please?
We mentioned that.
This one.
I don't know whether it's clear here or not, but you can see slight it is not clear here, but in the laptop it's clear. There is peripheral enhancement with central scarring or hypodensity, so suggestive of focal nodular hyperplasia.
What about Yersinia colitis? Can cause such Yersinia?
Yersinia? Okay, we'll come to that. We asked for Yersinia antibody, it was negative, but we'll come to that.
Large bowel, diffuse large bowel thickness with wall enhancement, few reactive lymphadenopathy seen in the CT with large amount of ascites. Also small, which we mentioned before, benign looking liver lesion at segment 6-7, which showed mild enhancement with central hypodensity, suggestive of focal nodular hyperplasia. Finding suggestive of shock bowel syndrome.
So the impression of radiologist that time when we discussed with him, he said this is most likely shock bowel syndrome rather than infectious colitis with the clinical scenario. He means hypoperfusion ischemia which is non-occlusive.
There's other investigations. Stool exam showed moderate pus cells with no ovoparasite seen. Next, please. Thyroid function tests were normal.
So again here, how we can manage this patient.
The high CRP, very high CRP, you have pus cells in stool, and you have white BCs of 39,000 with very high neutrophils.
So clinical scenario is against the imaging
does not go with-
impression. Okay. Any thought? How we will manage now? Now we came to the management level. Done, but you know it will not come in the same day. Patient is toxic, sick in front of you. How you will manage her? Endoscopy. Okay. Who's with endoscopy in this sick patient? Who's voting for endoscopy? 2. Okay. Anything else other than endoscopy? Diagnostic tab. Who's with acetic tab? Diagnostic. Okay, 5. Yes, Dr. Amr. What? We requested when we consulted to see the patient, but it was pending. So any other thought? So again, here we have clinical scenario suggestive of infectious process, most likely infectious colitis. Surgeon was consulted because of the abdominal exam and scenario of the patient which was where she was toxic. We treated her as infectious colitis. We resuscitated the patient with good hydration. We admitted her to ICU because of significant tachycardia. And we started on antibiotic, IV ciprofloxacin, metronidazole, and oral vancomycin with conservative management and DVT prophylaxis. So the surgeon saw the patient with us and they agreed with the management plan, no surgical intervention, and no signs of ischemia.
Okay. Later on the second day, stool for C. diff antigen was positive in 3 samples, all 3 samples. Stool for C. diff toxin also detected in all 3 samples. Next, please. So additional to previous conservative measures, IV ciprofloxacin was stopped once C. diff result came out. IV metronidazole and oral vancomycin was continued. Vancomycin enema was added to the management. Patient was seen by surgical team again, and they decided also no surgical intervention from their side. She had daily abdominal X-ray, abdominal girth, and abdominal exam in the first few days. Her symptom didn't improve much in the first few days, so 24 hours, which is tachycardia, abdominal pain, distension still there with diarrhea.
So again here, we have positive Clostridium difficile, but still, can we explain the presence of ascites, pleural effusion?
And these 5% of the hospitalized patients, they are positive for Clostridia, even not asymptomatic. It doesn't mean that she has Clostridia. And we cannot explain the ascites with Clostridia.
But still, this patient, she is significantly symptomatic.
Yeah, but if there is asymptomatic cases of, and it can be accidentally finding of Clostridia.
So that means might not be related to C. diff. So there is another entity you think of it. So what you will do next? Patient after first 24 hours did not improve.
Regarding this, the site is patient hypoalbuminemia, and what you have to search what is the resource of that, from where losing the protein. Is it cardiac issue is normal, and even the liver status, and still I don't know. This is the urine protein.
Urine we mentioned it is normal.
Normal.
There is no urine
So either in the
protein in the urine.
This is the enteropathy now. This is hypoalbuminemia. Ascites is due to decrease oncotic pressure, hypoalbuminemia may be related to neuropathy.
Okay. Yes.
It's very frequent if you check the albumin level in postpartum. So it's very frequent to find albumin level low.
But to level of 17?
No, but I'm telling you that pregnancy, it can induce this.
Yeah, hypoalbuminemia in pregnancy is common, but to level of 17 with evidence of ascites?
She has enteropathy, most
Okay.
probably.
So any other thought, any other differential? We don't know till now. Okay, so you will do acetic tab now. She did not improve in 24 hours. Who will do acetic tab? Okay, 4. But you are 4. Other people did not ask for acetic tab.
Sorry,
It will be positive. There is infection. It will be high positive. No rule.
usually in Crohn's disease,
It doesn't differentiate. No. It will make more dilemma, and it will not help here. You do yes, Dr. Aikad.
Calprotectin is it's a good to differentiate between irritable bowel syndrome or inflammation or infection. Yeah, functional or non-functional.
Okay. So who will go with sigmoidoscopy now? Okay. 5. Who will go with surgical exploration? Nobody, okay. So acetic tab and sigmoid, 4 to 5. Surgical exploration, nobody. Who will continue conservative management with antibiotic? Okay, I like it from Dr. Gar'awi. He agreed with conservative management. Okay. So we manage the patient again conservatively with antibiotic. We continue antibiotic and supportive measures. Majid.
Patient continued the same treatment for C. diff. She progressively improved slowly over a period of 2 weeks. No more abdominal pain, distension. She has regular bowel motion, no more diarrhea, no fever, and no more tachycardia. Repeated imaging showed interval resolution of ascites, interval resolution of mucosal enhancement seen before in the previous CT, and thickening of the large bowel. Minimal residual change seen in the rectosigmoid area. Delayed other labs, which is done took some time to come, which is culture were negative for stool, blood, throat, and vaginal swab. Listeria antibody and Yersinia antibody were negative. ANA was negative. And hepatitis screening with HIV, all were negative. Upon discharge, patient CBC were normal. The albumin was 24. So she final diagnosis. She has complicated C. diff infection with ascites, pleural effusion, query protein losing enteropathy, and peripartum omen.
So any comment at this level? So you agree. We'll go to topic review. What? No, she refused. By the end, we tried to convince her after resolution of her acute inflammation. She refused both acetic tab and sigmoidoscopy. But she said, give me time. I will follow as outpatient. If I need, I will consider it.
This is her, when she was discharged, her plan was to go to follow up in GI clinic with labs, plan for colonoscopy, for MRI to follow up the liver lesion. Topic review now. The C. diff infection severity scoring system and summary of recommendation treatment from American College of Gastroenterology in 2013, which is our patient fits a severe and complicated disease, which is any of the following attributed to C. diff infection: admission to intensive care unit, which our patient had, hypotension with without required of inotropes, fever above 38.5, which our patient had, alias significant abdominal distension, which our patient also had, mental state change, which is were negative in our patient, WBC above or equal to 35,000, which is also fits our patient, serum lactate level above 2.2, which were negative in our patient, and organ failure, mechanical ventilation, or renal failure, which is were not seen in our patient. So the treatment were vancomycin, which we start before orally 4 times a day, metronidazole IV Q8 hourly, vancomycin as a rectal enema, which is vancomycin 500 milligram and 500 milligram of normal saline as in 4 times per day. And the comment which we did also, surgical consultation. This is a protein losing enteropathy and ascites associated with C. diff infection, peripartum moment, done in this paper done in 2014 from UCLA Healthcare. This case report of a female which is 36 years old, admitted to hospital with perfused watery diarrhea, abdominal pain, fever, and nausea and vomiting. Past medical history was significant for cesarean section done for C-section done 2.5 weeks back. Prior to her admission, she received IV cefazolin preoperatively. Vital signs when she presented to them was blood pressure was normal, 123/75, pulse she was tachycardic 119, and respiratory rate was tachypneic mildly, which is 18, temperature 38.3, oxysaturation was 98. Physical exam remarkable for diffuse abdominal tenderness, otherwise unremarkable for other negative for other finding. WBC was 16,000, albumin was 30. Started levofloxacin and plus flagyl. CT abdomen severe pancreatitis showed and small amount of ascites. In the next 24 hours, the patient developed worsening of her condition and abdominal distension, pain, tenderness, consistent with peritonitis. WBC gone to 55,000, albumin gone down to 22, and stool were positive for C. diff. Still studies. Levofloxacin was discontinued. Oral vanco was added to the metronidazole. Repeated CT scan of abdomen 2 days later showed diffuse severe pancreatitis from rectum to cecum with significant interval increase from of ascites and small bilateral blue effusion seen with no evidence of toxic megacolon. In the next several days, the patient diarrhea, abdominal pain resolved, her oral intake improved. The patient underwent paracentesis and thoracentesis for the symptomatic ascites and pleural effusion. Discharge home on long taper of oral metronidazole, oral vanco, and made for recovery and resolution of C. diff infection. The final diagnosis was severe antibiotic-associated C. diff with associated protein losing enteropathy and ascites. This is now the topic review done to the 20th of December 1995, which is protein losing enteropathy associated with C. diff infection, diarrhea, but not with asymptomatic colonization of colonization. A prospective case control study. Enteric protein loss and nutritional status was measured in the patient with symptomatic and asymptomatic infection due to C. diff infection. So they saw the above parameter for the patient without diarrhea. So the case control with diarrhea had lower level of serum albumin, transferrin, and cholesterol than the one did the symptomatic case and control. In conclusion, protein losing enteropathy was associated with C. diff only if presence of diarrhea. Emergence of C. diff infection among prepartum women. This is a case control study of C. diff outbreak in obstetrical service in 2011 in Washington Medical Center in Seattle. The outbreak of 20 prepartum C. diff infection occurred in obstetrical service at the University of Washington Medical Center between 2006 April and June 2007. During the outbreak, there were around overall incidence of 7.5 C. diff infection per 1,000 deliveries. The prepartum infection compared to control was significantly associated with the following factors, which is cesarean delivery, C-section delivery, which is 70 versus 34%, antibiotic use, which is 95% over 56%, cryoamnionitis, which is 35% phase 5%, and the use of combination of ampicillin, gentamicin, and clindamycin, which is significantly high, which is 50% phase 3%. The use of combination antibiotic remained a significant independent risk factor of C. diff infection in multi-variety analysis. This is the conclusion. The outbreak was reduced after implementation of multiple infection control measures and modification of antibiotic use. However, sporadic C. diff continued for around 8 months after these measures slowed the outbreak. Prepartum women appear to be another population suspected to C. diff infection. This is a review regarding C. diff infection rates and spectrum of the disease among prepartum women at one hospital from 2003 to 2007, which is done in the paper in 2011. Prepartum women are at risk of C. diff infection, but the risk magnitude and clinical disease spectrum are unknown. So the 12 C. diff infection cases were found over 5 years, incidence of 0.7 cases per 1,000 obstetrical ward admission. So barrier antibiotic use was documented in 11 of the cases, and 8 of them were healthcare facility associated. The rate of C. diff following cesarean section was 2.2 in 1,000 live births compared with 0.2 per 1,000 following vaginal delivery, which is going up with the C-section. So this one acute topic review regarding acute C. diff infection in 2 Polish pregnant women, rupture of membrane in 2012. 2 cases acute C. diff infection during pregnancy in Poland. Both patients were hospitalized due to premature rupture of membrane at 15-28 weeks of gestation and had antibiotic prophylaxis and therapy. Both C. diff developed in the patient. The first patient was discharged on day 18 after treatment, but the second patient unfortunately died after 4 days of the hospitalization. That's all for this one, and thank you.
So this is for the first case. Any question?
Question to Majid.
Yes.
Is there any history of antibiotic?
No, according to her, none. She didn't take any supplement even.
At all, huh?
Yeah.
Dr. Abdullah Mutawwa. No, it's community
Maybe we don't
acquired.
know.
She came from the community.
During your literature review, how many case reports you come across?
Of C. diff?
A case of your case.
You mean as a topic review or?
No, it's case report.
Case report, I'll see, maybe 5 to 6.
So probably it's a good chance
Yeah,
to report this
it
case.
is. That's why we discuss it here.
It's a good case.
Okay, thanks. Any other comment?
I think we should not stop. Those cases is okay, but usually, if you are positive Clostridium difficile, will not exclude IBD, inflammatory bowel disease. We have seen cases with inflammatory bowel disease plus Clostridium difficile. I think colonoscopy. I'm not talking about these 2 patients. In general, I think we have to do it. Even for Clostridia is diagnostic.
Yes, I agree with you. IBD is a risk factor for C. diff. We try to convince the patient, even as outpatient, as follow-up after 3 months, but still she is reluctant to have the procedure.
The finding of Clostridia will not exclude another something else.
But clinically, she presented with acute diarrhea, and she doesn't have anything in the history to suggest chronicity or even IBD. And she did respond very well to the treatment with vancomycin and other antibiotics. So most likely the diagnosis is C. diff related. Yes, Dr. Badr.
The presentation is acute, and usually, what is the indication to do sigmoidoscopy or colonoscopy in the background of acute Clostridia difficile toxins? Indication usually, if there is acute presentation, and you fail to demonstrate there is Clostridia difficile toxins, and you still, if you suspect it, you can do colonoscopy or sigmoidoscopy, or if there is IELTS. Sometimes if there is this is an indication, but if you have approved with the stool here, you have 6 samples positive, and the presentation is acute. So there is no indication to do sigmoidoscopy. But I agree with you, you have to do colonoscopy in the future to rule out any other like inflammatory bowel
Last comment, because we'll go to the second case.
Last comment. If we have a dilemma like this between inflammatory bowel disease and infectious disease, and specifically in this case, I think doing sigmoidoscopy is not very invasive, because this patient doesn't have in the X-ray any symptom of toxic megacolon. So we can do it safely, and we will find a specific pseudomembrane, and we will have definitive diagnosis.
Okay, let's say I did sigmoidoscopy and tend to be there is inflammation, and it's not typical for pseudomembranous, but there is C. diff in the culture. How to differentiate between UC and acute colitis? Biopsy will show the same evidence of inflammation. Okay. If you have chronic, but she has acute. Yeah.
So we'll go next one.
So we'll move to the next case. This patient just referred to our service recently. We have some difficulty with this patient, so that's why we are going to discuss him here for help from the audience.
Okay, Bismillah. Start.
Bismillah.
Okay, the story started. Bismillah. The story started in 2013 when a 14 years old Saudi male known to have sickle cell anemia, short stature, presented to the emergency room with history of diarrhea, fever, abdominal pain for more than 4 weeks. Patient had 4 weeks of diffuse abdominal pain, cramping on off watery diarrhea, followed to occasional drop of blood from the anal area, and fever on off not documented. The patient had been seen in different hospital in Tabuk, where he was given antibiotic, but no improvement for his general condition. History of documented weight loss, undocumented weight loss, and history of preanal discharge for 2 months. There is history also of vomiting on and off. History of chronic back pain for more than 2 years. And history of jaundice for a long time, since, according to him, since childhood. No history of contactive TB and sick patient. And no similar illness in his family, or history of GI diseases. No history of skin rash, eye pain, redness. No history of joint pain or swelling. There is a past history of sickle cell anemia since childhood, and he's on hydroxyurea and folic acid with poor compliance. He used to have frequent attack of vaso-occlusive crisis during childhood, but according to last 4 years, according to his mother, he never have any crisis. So the lack good of detailed history and no official report, and they're living far away in Tabuk and following outside with different hospitals in their area. Systemic review were negative for other symptoms. Drug history was folic acid and hydroxyurea with he's not that compliance on them, both of them. Social history, living in Tabuk with his family, poor socioeconomic status, and studying in intermediate school with average performance. Family history has stroke in his father at the age of 55, sickle cell anemia, one of his brothers had it, and no history of any allergy to any medication or substance. This is clinical examination. Patient was alert, conscious, oriented, jaundice, but not pallor, which is strange for this one. Secular, vital signs, temperature 38.5, blood pressure was 98/63, pulse was 120, tachycardic, spot rate was 16, and saturation is 99. Small lymph node in the posterior rim of the sternocleidomastoid on the neck exam, and small right inguinal lymph nodes palpated. No skin or joint abnormality. And head, ear, eye, nose, and throat examination was unremarkable. Abdominal examination, no deformity or scars. Soft non-tender with palpable hepatosplenomegaly. BR examination showed 2 draining fistula with yellowish discharge. Didn't allow for digital examination due to the pain of the around the area. Chest, heart, and CNS was unremarkable. The musculoskeletal system also. This is investigation. CBC was 15.6, mainly neutrophils. Hemoglobin 9.6. Platelets was 560. Liver panel, ALT, AST, ALP was normal. Total bile was 37.5. Direct was 17. And GGT was 52, which is normal. Albumin was normal. Renal panel, creatinine, BUN, and sodium was normal. Potassium was also 4.37, which is normal. INR normal. LDH was normal, 143, which is good in his condition, which is sickle cell anemia. Amylase is normal. Protein 88, and globin is 49, which is high. ESR mildly elevated, which is 31. C-reactive protein 49. Corrected sodium was normal. Calcium was normal, 2.24. Anti-ASCA, which is negative. Yes. Anti-saccharomyces, anti-what? Yeah. Vitamin B12 was 520. Stool culture was negative. Stool ovoparasite also negative. C. diff negative. Quantiferon test for TB was negative. Thyroid function test was negative. Vitamin D was significantly low, 7.1. Urine analysis unremarkable. Blood culture sensitivity negative. Status screening were negative with HIV also screening. Fungal infection were negative. Positive second test conferred with hemoglobin electrophoresis. This is chest X-ray of the patient, which shows some fibrotic change. Also, this is the lateral. CT abdomen, mild circumferential wall thickening of the whole colon, suggestive of active colitis, query inflammatory, was infectious. Mesenteric and retroperitoneal lymphadenopathy, and moderate hepatosplenomegaly. Small bowel lobe are seen within normal limits. This MRI pelvis showed left parasagittal transsphincter fistula at 7 o'clock. The rectum has a thickened wall. Pararectal fat is edematous. Multiple slightly enlarged lymph nodes in the pararectal fossa and in inguinal region bilaterally. No abnormal collection or mass is seen. This is gastroscopy of the patient, which showed mild gastric lithium in the antrum, otherwise unremarkable. Biopsy showed no significant pathology. Colonoscopy of the patient showed 2 renal fistula with minimal discharge, but no swelling, all in duration. Narrowed and inflamed anal canal, and few rectal ulcers. At sigmoid, 2 area of longitudinal and deep ulcers with couple stoning and scattered abscess ulcers. At descending, 1 area of longitudinal and deep ulcer with couple stoning and scattered abscess ulcer also. Transfers to cecum, scattered abscess ulcer only. Terminal ileum was normal. Conclusion, colitis and skip lesion, more severe on the left side, renal disease, normal TI. This is a picture of the patient, colonoscopy. The biopsy of the colonic biopsy, terminal ileum, no significant pathology seen, which is the cecum, moderate active colitis, collection of giant cells, and ill-defined granulomas. Ascending, also mild active colitis, collection of thyroid granulomas, and Langerhans type giant cells. Transverse, also focal ulceration, however, no active colitis seen. Splenic flexure, epithelioid granulomas, however, no ulceration or active inflammation seen. Descend moderate to severe active colitis with ulceration, ill-defined epithelioid granulomas. Sigmoid also mild active colitis, epithelioid granulomas noticed. Rectum severe epithelioid granulomas with Langerhans giant cell. Impression of the histopathology, most likely they present tuberculosis. Other features of Crohn's disease such as prominent lymphoid follicles and deep fissuring ulcer are not seen. And Ziegel-Nielsen for acid-fast bacilli is negative, however, does not exclude the possibility of tuberculosis. Collaboration with other clinical and endoscopic finding is recommended. It is written in the summary of the biopsy result. Chronic biopsy, AFP, TB culture were negative, TB PCR, CMV, PCR were negative also.
So here, what is the impression? Now we have young patient, he came with perianal disease and colitis with scuba-turn. He had hepatosplenomegaly, he had lymphadenopathy. And histopathologist insisting this finding goes with tuberculosis. So what do you think and what do you recommend?
Reading by second pathologist, GI pathologist.
Okay. What else? Other suggestion? Yes? So we'll treat him as TB for 2 months, then follow up. Okay. Any other thought? Yes, Noah?
PCR was from the tissue?
Yes, TB PCR from the colonic tissue.
I mean, still, the TB can present with this, but I mean, if it's negative, the yield is very high from the tissue for PCR. So I will go with inflammatory bowel rather than TB.
Okay.
I don't know. I'll change a little bit from the issue of the colon. I'll go to the liver. He has conjugated hyperbilirubinemia.
Yes.
And fever. I don't know. This maybe sickle cell hepatopathy or maybe a stone. Was an MRCP done? I don't know.
Okay. Ultrasound was done initially. There was no biliary dilatation and looks fine apart from hepatomegaly. Okay. So, any other thought? CT? Yeah, we mentioned that. He has pancolitis, more severe on the left side. We has lymphadenopathy, hepatosplenomegaly.
I think a very important thing is expert GI pathologist. If he need more, I will take more biopsy, do another colonoscopy, take more biopsy, just to confirm either TB, there is TB or not.
Lymph node biopsy. Small one, sub-centimetric lymph node, the one accessible. The large one is intra-abdominal, so patient is difficult, by the way. We will hear in the scenario he's difficult, not agreeing for intervention or any procedures. Yes, Dr. Fateh.
The sickler patient, they have usually autosplenectomy.
Yeah.
So the finding of splenomegaly and hepatomegaly, with this, it should be raised as a systemic issue. Like with this Langerhans, you have to think of either tuberculosis or histotoxosis.
Excellent.
Histocytosis or histocytosis.
Histocytosis or TB, okay.
Or TB. It's not only TB, but the feature of perianal disease and this one, we think of IBD, but in the future of
combined process.
Combined with hepatomegaly, we have to think for systemic disease.
So here we have differential. Somebody mentioned that it's pure IBD. Others mentioned could be TB or lymphoma or histocytosis. Some mention it's combined disease like IBD with superimposed other diseases like malignancy or chronic infections.
But I think this is one of the dilemma in the clinical practice is when is it TB, is it inflammatory bowel disease, and sometimes there is no really clear cut, and everybody thought is right. You cannot tell or stick to one diagnosis or one differential diagnosis. And it depends sometimes on personal opinion how you will approach the patient. But probably I will go with give him anti-TB first and see the clinical response. Just and some they will depend on because the clinical scenario and the picture, the endoscopic features are going with inflammatory bowel disease and Crohn's, especially with the perianal fistulae and these stuffs. So again, I said it depends on the treating physicians.
Okay. So we'll go to our initial impression and plan.
There's a historical association between Mycobacterium avium paratuberculosis and Crohn's disease long ago, and it was initially thought that it could be a cause. This could be an incidental finding or a co-finding, but still we have to rule out. Did they do a PPD for this patient?
Quantiferon was done, and it was negative.
Okay.
So here we have the primary gastroenterologist at that time. He had a meeting with the histopathologist, with the infectious disease consultant, and with the radiologist. They reviewed the case and they agreed to treat initially as TB with anti-TB. Patient was treated with anti-TB for 10 months, and he was following with both gastroenterology clinic and ID clinic. He showed some improvement, which is good according to him, but not complete. He did not come back to his baseline or normal life. And his compliance to treatment was questionable as well.
Okay. For this patient, he had a follow-up CT abdomen after completion of the anti-TB medication. Previously noted diffuse thickening within the colon had resolved. There is remains of mildly enlarged lymph nodes within the perisacral and rotoperitoneal region, the largest measures which 8 and 12 millimeter.
So imaging of colitis resolved, but remaining we have lymphadenopathy.
Patient had follow-up MRI pelvis after completion of also TB. Previous reported transsymplectic fistula is improving, no abscess or collection. Lower rectum showed enhanced mucosal, slightly thickened wall, which is seen in the previous MRI. Multiple enhanced lymph nodes were again noted in the ischiorectal fossa. Patient follow-up, patient disappeared after that, did not attend to the OPD and lost contact with the hospital. Again, in July, after 2 years, almost more than 2 years, in July 2015, the patient came to the ER with a similar history, which is diarrhea, fever, and abdominal pain for 4 weeks. Among almost the same initial presentation, which is febrile, renal disease, leukocytosis, neutropenia, high inflammatory markers, which is ESR120, C-reactive proteins 45. CT abdomen, more thickened, is noticed as the distal rectal and pre-rectal lymph nodes, multiple enlarged lymphadenopathy in this one in the abdomen, and changed comparison to the previous study done 1 year back. Small bowel looks unremarkable, abnormality seen, suggestive of IBD. Hepatosplenomegaly noticed, but no biliary abnormality seen. Diffuse mixed lytic and sclerotic change of the whole skeleton are noticed with evidence of T9 compressed fracture. Overall finding may raise possibility of proliferative disorders such as lymphoma or leukemia. Clinical collateration further workup is suggested. There is MRI spine, which shows there is marked compression of D9 vertebra, but no bone marrow edema or sign of acute inflammation. No evidence of there is evidence of central lytic lesion in D11 and L2 vertebral body, which appeared surrounded by sclerotic margin, but no paraspinal soft tissue density or cord compression. The bone scan done, which is no evidence of acute bone lesion in dorsal spine, functional asplenia, which is infarcted spleen. This is a gastroscopy which is repeated in 2015 in July, which is showed mild anteroerythema biopsy, which was normal in the previous 2 years done gastroscopy. Now it's positive for multiple lymphoid granulomas with giant cells, negative for atrophy or intestinal metaplasia. The Zielinelson stain was for acid bacilli was negative. Tuberculosis cannot be excluded as before. Previous biopsy in the colonoscopy suggested, which is done 2013. There's a colonoscopy done, which is after this one under GA 2015, which is severe perianal disease with fistula. Scope telesigmoid showed severe ulceration with variability and easy bleeding. starting from the rectum till the sigmoid colon with some area of cobblestoning. Rectal biopsy, which is showed multiple fragments of rectal mucosa showing vithelloid, again granuloma with large type cells. No active inflammation, no ulceration or crypt distortion seen. Also no regenerative changes. Sigmoid colon biopsy, mild focal active inflammation, no granulomas or ulceration. Nielsen for acid base bacilli was negative. Feature of Crohn's disease, such as deep ulceration, permanent lymphoid follicles, active colitis, and regenerative changes are not seen. Clinical pathological correlation is recommended. I discussed this case also with the histopathologist who's done both the slides. She strongly agrees that this is not Crohn's disease because superficial ulceration. There is also the most likely it's TB. It's not Crohn's disease, and she strongly suggests if we took the slide to any other hospital, he will say the same.
Okay, we took slides to another histopathologist in another hospital, and said fake comment. He did not say this is suggestive of Crohn's or TB, but he said can be with both, but he cannot raise the possibility of either.
This hospital calls. Patient had sigmoid perforation, post-colonoscopy, underwent surgical repair with colostomy, admitted to ICU, developed sepsis with WC reaching to 29,000, had minimal pus discharge from surgical wound, treated with IV antibiotic conservative measures. He was improved progressively, discharged from ICU. Patient was seen by hematologist, IED consultant and surgeon, planned for bone marrow biopsy for further workup for the lytic lesions. MRCP and the disease itself, the entity, and MRCP considered to be considered taken by surgical biopsy, full thickened biopsy from the wall, colon wall. To be considered also liver biopsy if bone marrow biopsy MRCP is not conclusive. Patient and his family signed DAMA and refused to have any further intention after they had this multiple complication.
So again, we are in dilemma here.
I think this patient who has sickle cell disease, I think he has a history of repeated blood transfusions.
Yeah.
I think it would have been worse to check his iron load status, his transferrin saturations and ferritin levels.
It was checked and it was within normal range, the transferrin saturation, yes.
Given the history of transfusions.
By the way, he had bad sickle cell disease while he was in his childhood, but his mother claiming, she's telling strange for me, he is sick and he's acutely ill from the disease, IBD or other disease, GI disease, but he never had crisis like his past.
Just I have a comment regarding if there's any role of the hydroxyurea. I'm not sure about the hematologist. They showed some reporting myeloproliferative hemorrhaging exchange. So this
Okay.
is possible.
That's why we raise the possibility of myeloproliferative disorders, lymphoma, TB, histocytosis, histoplasmosis as chronic fungal infection, extrapulmonary, I mean. So
after he had the unfortunate perforation, was it possible to get a complete lymph node out of him when he was open?
So the surgeon took him, and unfortunately, nothing was done. Even they did not take surgical biopsy. We asked for that. Yeah, lymph node not taken, and the surgical, even we asked for full thickness surgical biopsy was not taken. Yes.
I would consider that the patient is having flare-up of his OTP, and I would start having second line, especially that we don't directly observe the therapy and we should be directly observe the therapy. I would like also to consider excluding mycobacterium aviary consideration, especially if the patient has no immunity, even though it's affecting the bone marrow.
So we don't have solid diagnosis for TB at beginning, from beginning. So still we discuss with the ID consultant the possibility of resistance organism or other mutant organism, but the possibility of TB is still there, but I will not consider it as high on the list.
Yeah, I agree with you, Mohammed. At this stage, probably I will consider inflammatory bowel disease and I will treat him for inflammatory bowel disease and I will see. Because I'm not going to repeat his anti-TB treatment again. He was treated for 10 months and there is no improvement. We still have active disease in the rectum, perianal disease. So the clinical, what confused the picture is the pathology report. If you go back to the clinical scenario, it's fulfilling the criteria of Crohn's disease.
Yes.
And there is nothing 100% perfect all the time.
Okay.
So probably sometimes you have to go with your clinical.
So probably initial impression I think was with IBD, but the histopathologist confused us and opened our eyes to the hepatosplenomegaly, lymphadenopathy, and pathological fracture of the spine. Then we start thinking of other rare and differential diagnoses.
This is what I want to comment about. The lytic lesion and the fracture, it will not go with the IBD.
Yes.
The hepatosplenomegaly, it could be, but it's not the common feature of IBD. I think liver biopsy or lymph node biopsy will help in this regard. And I don't know if you do MRI pituitary just to rule out histiocytosis.
Not done, but why? Okay. Yes, Nawaf.
Does he have any lymphadenopathy apart from the abdomen?
Yes, he has a small subcentimetric in the cervical. Clinically not significant.
So I'm not sure about lymphoproliferative. Can cause fistulizing of the colon. The TB will know and IBD, but lymphoma I think it's less likely or unlikely to present.
Okay, but normal. 2013 was normal. Now when he came with acute illness recently and had perforation, it was rising, but we don't know whether it's related to possibility of lymphoma or to the acute illness. Yes, Dr. Agab.
Regarding the surgical specimen, there is a large surgical specimen.
No, they did not do surgical specimen. They just took the perforated area, they make it a stoma, colostomy. Yes, Dr. Badr.
Now, this patient who has a differential of TB and Crohn's disease, we gave treatment for TB for 10 months. Why not going to the second differential diagnosis?
Crohn's? But I will treat with immunosuppression. If you suspect histocytosis, histoplasmosis, and TB, so you will just kill the patient with anti-TNF, and he's candidate for anti-TNF if he's IBD. Okay, for the sake of the time, we'll proceed now.
So the course patient went home DAMA, an oral antibiotic given OPD with surgeon and GI, advised any complaints to come back to any time. So the patient came back last week and agreed to undergo briefest plans and investigation. He underwent bone marrow biopsy, waiting result, booked for MRCP.
MRCP done this morning, and it was, apart from hepatomegaly, unremarkable. He came back, and initially when he came back, he said, I agree to do whatever you want. And we planned for bone marrow, then after that, if not conclusive, we'll consider liver biopsy. Then if we ruled everything in our mind, we will treat him as Crohn's disease. But unfortunately, this morning we asked him for colonoscopy through the stoma with using gastroscope. He refused again. So, and liver biopsy, he refused again.
What you mean by no conclusion,
I mean, if it came back normal, that means there is at least no invasive disease like lymphoma or fungal infection infiltrating the bone marrow caused the whole scenario, like histocytosis or histoplasmosis. So then we can treat him with the immunosuppression in the future. So what do you think, what is your advice now with this patient before we go to next quick scenario, only 2 slides? Okay. Who agree with lymph node biopsy?
Surgical excision or lymph node biopsy is probably the right answer.
Okay. What other suggestion for this patient? Refused biopsy. We asked him initially, he refused bone biopsy.
I think you have penetrating disease, you have fistulas, and the pathology is saying superficial ulcers. You see? I think there's some discrepancy between the clinical and the pathological scenarios.
But he's confusing the treating physician, if I am the one.
The chance of Crohn's is very high.
If he refuses to do the colonoscopy, he can do it in another colonoscopy.
Yeah, we gave him the offer to go to any other hospital. Even we try to help him, we'll facilitate the acceptance at any other hospital, but he's not interested to go any other. So he wanted to stay with us. So actually we'll try to convince him again for lymph node biopsy, for colonoscopy. We don't know, we'll wait for the opinion of the infectious disease. Okay, so you agree, most of the people here agree that it's most likely IBD, with exception of some suggestion about myeloproliferative disorder or chronic fungal infection or other organism like TB. He is underweight, yes. Malnourished, yeah. Yeah, he has weight loss. Lymphoma, okay. So anybody will treat now as a Crohn's disease? Will start treatment? 2 persons. Okay. Okay. Initially, last admission I was with the treatment, but then somebody pushed me not to treat. Okay.
I mean, if you give the patient Bentaza,
Yeah, but Bentaza will not treat him. He has bad disease.
If you give them budesonide, nothing will bad will happen. So, in my opinion, if you want to try something, the safest of the two would be Bentaza and budesonide.
But he has bad perianal disease, bad colonic disease.
Budesonide and as well. I mean, there's nothing wrong with the high pass metabolism, first pass metabolism. So the drug is relatively safe. If you use it for even just 1 week.
He was treated with 5-SA for the initial period with anti-TB. But
I'm not sure what the others' experience is, but I think it is. But I mean, his disease is most likely rectal, they're saying. So I think.
Dr. Garao, you have any comment? Yeah, it was normal. Yes. Colonoscopy advanced up to almost 30 cm, and it was normal, and the imaging was normal. And biopsy from the TI was normal. MR recently they refused because of the clips of the surgery. They said it makes a lot of artifacts. Okay, we'll go to this quick scenario. 27-year-old male diagnosed in private hospital to have Crohn's disease, and he was treated with prednisolone there. His brother has Crohn's disease as well. Patient was maintained himself on 20 milligram of prednisolone daily because he's telling if he will start tapering the dose, he will have the symptoms. He came to Security Forces Hospital for re-evaluation and further management because he's running out of money in the private. CT abdomen showed terminal ileitis with mesenteric congestion and lymphadenopathy. Colonoscopy showed cecal inflammation with few ulcers. Ileocecal valve was narrowed and inflamed, cannot intubate the TI. Biopsy taken. Ileocecal valve biopsy, almost the same finding as the previous patient. Epithelial granuloma, Langerhans cells, and inflammation. And showed mild active colitis, but no ulceration or granuloma in the cecum. There is epithelial granuloma as well. Pathological finding in this biopsy are, this is the opinion of the histopathologist. Mild right side colitis, non-caseating granuloma, however no deep fissuring ulcer, prominent lymphoid follicles, or moderate to severe active colitis noted. Acid fast bacilli negative, the possibility of Crohn's disease cannot be excluded. Here, they said possibility of Crohn cannot be excluded. The previous patient, they said possibility of TB. Okay. Clinico-pathological correlation is recommended. How you will manage this patient? He's on steroid. He was diagnosed as Crohn's. He has family history of Crohn's disease. And he came to you in the clinic with prednisolone 20 milligram. Okay. Short terminal ileitis. TB. No, this can happen with IBD. He will have weight loss. He will have, someday will have mild low-grade fever. So cannot differentiate. Yes?
Even the steroid use, it's definitely rules out the
Okay.
treatment, more aggressive treatment.
So you will start tapering steroid and add Imuran. Most likely. This is what everybody will do. Agree? Okay, let's see. Patient was started in azathioprine, tapering down of prednisolone after we convinced him because he was reluctant to taper down the steroid. Patient was given follow-up in IBD clinic. Labs call after 3 weeks. What do you think they are telling? Yes, acid fast bacilli positive. So, what about the lab? This is microbiology.
This takes 3 weeks, you know. There are symptomatologists saying that I cannot rule out Crohn's disease when it's actually TB. And I'm not saying the other way around in the first case. I mean, clearly there's not a consensus of opinion on this slide.
So what you will do with this patient now? He's not my patient, but both patient not mine. The recent, but what? Clinical, I did not see him, but Dr. Abed, he's patient of Dr. Abed.
For the last 4 months, he started to have bloody diarrhea of about 10 to 15 times per day. He will start on steroid with some improvement. That's why he didn't want to discontinue or taper down the dose. For the last 4 months, he had loss of weight for about 10 kg. There is no B symptoms. There has no night sweat, fever possibly. And this is the only complaint. No, he's the same. He has no change in his symptom. It says the diarrhea is there, and the abdominal pain is there.
So we will wait for the culture, final culture to be released to make sure. Even the microbiologist initial impression is typical TB. So he was started on anti-TB, and we stopped the other medication, tapering down rapidly the prednisolone and stopping the Imuran. Any further comment or conclusion? Yes. Possible have superimposed both disease, but he did not start significant immunosuppression. He was just started a small dose of steroid, 20 milligram. 4 months. Yes, 4 months. Yes, Dr. Karawi.
Your patient with the fistula, I think there is a problem with the compliance. If the small bowel completely is free of any changes, of any pathological Crohn's disease, typical changes, then the possibility of Crohn's is more. And I think there's a problem with compliance to treatment. And he may be building more resistance to drugs if the compliance is not good. So maybe it's still TB, but badly managed by the patient.
Yes.
Compliant.
Agree. Shukran. Thanks for all.